Use gestational age to anticipate infant size and the need for surfactant. Have ready a room temperature vial of Surfactant, a syringe, 5 French end-hole feeding catheter, and a sterile cutting tool. Draw Surfactant into the syringe through a large gauge needle. Cut the 5 French catheter long enough so that it will pass through the ET tube with the distal end just above the carina. Start the dosing procedure as soon as possible after birth. Identify the correct dose on the Surfactant dosing chart based on the birth weight. Then expel excess Surfactant through the catheter. This primes it, leaving a full dose in the syringe. Lower the head and one shoulder slightly. Insert the shortened catheter fully into the endotracheal tube. Inject the first fractional dose. Ventilate for 30 seconds after each fraction to distribute Surfactant. The ambu bag should be capable of delivering 100% oxygen to prevent cyanosis and should provide adequate air exchange and chest wall excursion. Next, rotate the infant so that the head and same shoulder are slightly up. Inject the second fractional dose. Again, ventilate for 30 seconds. Vary the infant's position with each of the 4 fractional doses. This allows Surfactant to reach all areas of the lungs. The sequence of positions doesn't matter as long as all 4 are used during dosing.
A dose of Surfactant is 100 milligrams phospholipids per kilogram birth weight. Each treatment is administered in 4 aliquots, so 4 fractional doses comprise 1 complete dose. Each vial of Surfactant contains 25 milligrams of phospholipids per milliliter suspension. Refrigerate Surfactant in the carton. Inspect the vials before using them. Surfactant should appear off-white to light brown. Swirl the vial gently. Do not shake it as it may foam the suspension. Warm it to room temperature before use. Never warm Surfactant using artificial methods. Surfactant remains stable up to 24 hours after warming. If it is not used within that period, it may be refrigerated once for later use. Surfactant dosing may also begin after RDS is detected. This rescue is indicated for infants with respiratory distress syndrome confirmed by X-ray and severe enough to require assisted ventilation. Infants with RDS should be treated as soon as possible after being placed on a ventilator. The recommended dosage of Surfactant is always based on birth weight, so you won't need to reweigh the infant to calculate the dosage. For the rescue strategy, administration is very similar to prevention. In the NICU, Surfactant may be given through a suction adapter. If so, be sure to cut the catheter long enough to accommodate. Gently incline the infant with the head and one shoulder up. You can use the bed to position the infant if you prefer. Administer the first fractional dose. Ventilate for 30 seconds. Then, repeat the process for each of the remaining 3 fractional doses. Reposition the infant before each aliquot. When the final aliquot has been given, remove the catheter without flushing it and ventilate.
If respiratory distress continues, up to 3 subsequent doses may be administered. Retreatment should occur only if the infant has RDS, remains intubated, and requires at least 30% inspired oxygen to maintain an arterial oxygenation of less than or equal to 80 torr. Retreatment with Surfactant is virtually identical to initial dosing. However, wait at least 6 hours between treatments. As always, be sure to warm the drug to room temperature for each treatment. And make sure the infant is suctioned and stable. Adjust the ventilator settings each time. In clinical studies, ventilator settings were different for repeat doses than for the initial dose. Increase the concentration of inspired oxygen by about 20%, or an amount sufficient to prevent cyanosis. Set a rate of at least 30 per minute with an inspiratory time of less than 1 second. You can always adjust these settings to ensure adequate oxygenation and ventilation. After dosing, remain with the patient until stable. Change ventilator settings as compliance improves, or if you detect acute deterioration.
Regardless of the strategy used, certain observation and monitoring procedures should be followed. Anticipate marked improvements in oxygenation and lung compliance within minutes of giving Surfactant. Stay with infants after dosing. Closely monitor oxygen status, airway pressure, and respiratory rate. When compliance or oxygenation improves, or if cyanosis or bradycardia occurs, adjust the ventilator appropriately. In controlled clinical trials with Surfactant, the most commonly reported adverse events were transient bradycardia and oxygen desaturation. Don't suction the endotracheal tube within 1 hour following a treatment unless occlusion is suspected. Continue to ventilate as needed.